So what I want to propose to you is that right now we're kind of in a locked room. And I use this as a metaphor for the notion that in healthcare right now, we use the term social determinants of health. We are thinking about how we're going to address these non-medical determinants of health. But we kind of go around in a circle and we end up right back at what do we do as healthcare practitioners to address the non-medical determinants of health. And many of Dr. Hansen's examples try to get us out of the locked room, right? So in the locked room is the healthcare system. How do we drag ourselves out of that locked room into the community? And what we're doing with this pilot is moving from the healthcare system out into the community. And you're literally going to move into a series of exercises that helps us to think about systems change, policy change, institutional change, which requires that you wear two hats almost. And what we're thinking about with this pilot is how we merge the roles that we take on, both our role as health practitioners or medical students, and the role that we assume as members of a community, members of a society. And so at the end of the day, this pilot is presenting you with an opportunity to merge those roles. But again, it does require us to move from out of the healthcare system, out into the community, interacting literally at the community level. This is the Robert Wood Johnson Health Rankings. What you see in this model is what makes up health. To what do we attribute population health? And what I want to call your attention to are the blue boxes moving over to the right. And you'll see health behaviors at 30%, clinical care at 20%, social and economic factors 40%, and then the physical environment 10%. And so literally what we're saying is that clinical care or health care makes up only 20% of what it takes to make a population healthy. And I want you to keep that in mind, right? So if we keep doing healthcare, how do we begin to address the non-medical determinants of health? How do we actually make those populations healthy that are most vulnerable? We've got to think about this differently, which is the reason for the concept of structural competency that we're introducing with this pilot.
Next, we're going to view two models that will help us to understand why we are conducting this program. The first model you see represents the bigger picture. Let's say we're looking down from a 40,000-foot level. This model is explaining the creation of inequities. When I started working on this model in 2000, my goal was to create a model of how inequities are formed and have it work in any society or region, including the US, Canada, the UK, for example, or the West Coast versus the South here in the United States. So the components of the model are high-level general representations of key factors that create inequities. I also like to say that with this model, one could identify the points where we need to work to address inequities. I want to point out the top of the model where it says Geospecific Societal Toolkit. This is where we have the opportunity to plug in the specific values, ideals, narratives, beliefs of a place that drives the actions and behaviors in any given region. You see the box that says assignment of meaning. This is where those beliefs, values, and narratives are used to label and interpret phenomena. They work like a silent script, perpetually dictating how we respond to phenomena like skin color, or the word immigrant, or the notion of West Side, or even the East Coast. The minute we hear those words or see images, our silent beliefs, values, and narratives at the top of this model kick in and call to mind images and ways of seeing and thinking about that thing. From there, the rest of the model's components represent high-level outcomes that can be found in any geopolitical region or place, including, for example, a set of public policies that drive the outcomes at the bottom and that drive good or poor health or inequities. In the case of the DDRS pilot, we're trying to determine how we move our efforts from the bottom of that model so that we're not just working on people once they become ill or become sick. And you should remember, we were trying to move from downstream. So you see the boxes on the left, downstream to upstream. Now, let's discuss how we're measuring the knowledge of the participants in the pilot. Note the little purple boxes. These are levels of proficiency of structural competency. And we are moving you from different levels of structural competency, starting at level 1 to proficiency at level 4. Level 4 proficiency is where we want to get, and this involves understanding how we can do work around systems, structures, and policies to achieve high-level macro change. But remember, we do start at the top of this model, and what is really driving the inequities at the bottom, which I think is a significant part of this model, is our geo-specific toolkit, the ideals, values, beliefs, and narratives in any given society that establish how we think about social status. Let's go on to the next slide. Again, this next slide explains more clearly the 4 levels of proficiency. And we're moving you from different levels of structural competency from level 1 proficiency to level 4. I'm not going to read each box. You can see what they represent. Level 4 proficiency is where we want to get. And this involves understanding how we can do work around systems, structures, and policies to achieve high-level macro change. And so the question eventually through all of this pilot is, how do we get to level 4 proficiency, where we begin to undo socio-political context and historical factors that are still shaping the inequities that we see in the present day? And that's the question that we're trying to answer. In the journey, we're going from downstream to upstream, learning about and creating efforts to undo the past, which still works in the present in a discriminatory manner. And we're trying to work right around level 4 proficiency. Next, I want to go quickly through 2 more slides, one on cultural competency versus structural competency, and then the last model that brings us closer to how our DDRS pilot works more specifically. A quick but important detour is to consider where cultural competency fits as we examine structural competency in this pilot. Today, we think that cultural competency is problematic in several ways. It clouds the larger problems that contravene healthcare and medical interventions. So things like poverty, historical discrimination and racism, a poor economy, the lack of long-term investments in communities where marginalized groups live, these are all factors that contribute to good and poor health. But these factors get lost under a cloud of culture where we associate poor health with a group's culture and fail to see and understand the role of those larger issues. Cultural competency does indeed have a place in bridging communication gaps and building trust, but the concept is not large enough to extend itself to contributions of institutions, systems, policies, and markets in shaping the health of marginalized groups. And that's why we are using this concept of structural competency and emphasizing it in this pilot. So again, this last slide, I want to go through it, and it's more grounding for the DDRS pilot. This is the model of the pilot that explains in more detail how we develop structural competency. Recall that we said the first model operated at a 40,000-foot level. Well, this model fits within that first model, but zeroes in on how we might change the very top of our first model by addressing the geospecific toolkit and the beliefs, narratives, and values that inform how we think about social status. This model also explains how we go about altering stigmatizing discriminatory racist policies, programs, structures, and systems which is also a deeper dive near the top of that first model, because at that point, we're working around the policy structures and systems. All of the orange colored components are new and reflected in this pilot. The dark blue boxes are what currently exists and exhibit how things are. The red arrows reflect what should be altered by a greater understanding of structural factors. So what we're doing is grounding you in context and historical and structural issues, which is one of the orange boxes on the left. And we can trace how these factors, context and historical and structural issues work as we integrate them into your medical school journey, which is in the dark blue boxes at the top of the model. In this case, our efforts are aimed at building into your journey through medical school knowledge and awareness of historical, institutional, and structural issues and socio-political contexts. We're layering it into the way that you have already been socialized and brought up and taught by your parents, your community, in the settings that you've been in. Now, the orange boxes are also integrated along the bottom of the model, where we add these factors into how you understand illness and marginalized populations. You can see how behavior is shaped by these orange box factors. And then instead of viewing trauma from historical issues and discrimination and systems of poverty, we hope that you will not equate them with culture as we move forward through the pilot. And you can see this on the right side with one of the red arrows. If you look at the box labeled practice, typically, once you go through medical school and you begin your practice and you see trauma, you might interpret that trauma as culture. What we're hoping is that by adding in the orange boxes, you will see that trauma as a result of lived experiences, historical, institutional, and structural issues, having a greater understanding of the trauma you see as not coming from people's behavior or their culture, but from these other factors in the orange boxes on the left. The last part of the model that runs through the center left to right and up and down in the light blue boxes exhibit the work in a community setting to study, organize with, and work alongside a community group to change a structural problem. And so in this way, we reach level 4 proficiency when we get to the light blue sections of the model, where you are competent and proficient enough to work with community groups to change the kinds of policy structures and systems that make it hard for them to flourish. Now I'm going to turn it over to Helena Hansen, whom I consider to be one of the pioneers of structural competency, who is still doing groundbreaking work on this concept today.
I just want to point out that structures interact with culture, right? Culture, structures, our institutions, our policies, they are a product of our culture and vice versa. Now, structure, on the other hand, is a term that comes from the social sciences that only in the past year or so, with the term structural racism being taken up by New England Journal of Medicine, Journal of American Medical Association, in response to the movement for Black Lives. Structure has not been so widespread a concept in clinical training until this moment. And it comes from the social sciences, where we're really focused on things like community organizations, health relevant sectors like schools, housing, law enforcement, urban planning, and also public policies. These are structures that really have a big influence on health outcomes. And I'm going to take just a moment to distinguish structural drivers of health from social determinants of health. It's a nuance that I think is really useful to call attention to, because in clinical medicine, what we're beginning to do now, we're beginning to screen for social needs when we see a patient in order to address social determinants of health. So we're beginning to, for example, ask patients, do you have stable housing, as a part of our assessment? Do you have access to fresh food? So those are social needs. What we don't often do in clinical medicine is back up and ask, why is it that certain populations have such higher rates of unstable housing than others? Just as an example. And if you start to dig into those, you'll see that there are these structures, these largely policy level structural forces driving those differences in how much people have access to affordable housing. So there are city and state zoning laws and development plans that displace large numbers of low-income people, often Black and Brown people, from their housing. There's predatory lending. Many of you were young, I think, during the 2008 crisis, but that was really due to wide-scale practices of giving bad loans to low-income, largely Black and Brown homeowners. And there are lots of layers of public policy that don't account for the need for affordable housing and often create shortages of affordable housing. And these are often focused on low-income Black and Brown communities. So that is a structural driver of the social determinant, which is insecure housing. And then the health outcome is increased risk of chronic infectious disease, psychiatric disorders, high rates of hospitalization, rehospitalization. So these are things you're going to encounter in the clinic and in the ER over and over and over again. You're going to encounter the health consequences of unstable housing.